Back to the next session and final keynote presentation for the conference. International Clinical Perspective on New Value-Based Funding Models with Dr. Tobias Wirén. Introducing the session this afternoon is Pricing Authority member Glenn Appleyard.
Good afternoon. We hope you're enjoying the conference program so far. I'm Glenn Appleyard, and as a member of IPA's Pricing Authority, it gives me great pleasure to introduce the next keynote session, International Clinical Perspectives on New Value-Based Funding Models, presented by Dr. Tobias Wirén. Dr. Wirén is a medical doctor and an orthopedic surgeon at Capio St. Göran's Hospital in Stockholm, Sweden, and he was head of the department from 2007 to 2018. Since 2017, Dr. Wirén has been the manager of the Capio Orthopedics business area in Sweden, covering high-volume arthroplasty units. Dr. Wirén is involved in the development of bundled payments for hip and knee procedures in Stockholm since 2009. His presentation today will discuss how clinical leaders translate the ambition of new reimbursement systems into evaluating activities, the bundled payment model, and how its introduction in 2009 has taken orthopedic surgeons on a challenging yet successful road to happier patients, better quality, and improved accessibility and reduced cost. Dr. Wirén will take us through the mistakes, the obstacles, and the rewards of a system where specialisation drives quality and quality drives productivity. We hope you'll enjoy this session.
Thank you, Glenn and Julia, and a good morning from Stockholm, Sweden. It's a new day and endless possibilities. To be or not to be of true value, that is the question. And that was the question I asked my orthopedic surgeons in Stockholm as I was trying to explain the principles of a new bundle payment model for primary hip and knee arthroplasties in 2008. As an orthopedic surgeon, I could talk for hours about fixing fractures, about titanium implants, plates and screws and metal rods, and intricate contraptions. And the more gadgets I could master, the faster my career would be. Better pay, more stripes on my coat, and a better reputation. And if I solved a complex problem in a complex way, I would be a hero. But if the solution was simple, I would be an incompetent moron. So quality of care was often being confused with adding more expensive elements of the treatment, not with doing the right thing for the right patient at the right time. Like, for example, putting iodine wraps across the surgical field that didn't prevent infection, or putting different types of drains into joints that didn't decrease bleeding. And in our reimbursement system, we were often financially rewarded when we used a complex and expensive solution instead of a simple one, despite a similar outcome for the patient, like fixing a fracture that nature would have healed itself, or using a really intricate contraption to fix a simple fracture. But traditions and habits are being challenged, and simplifying things and making sure that every step adds value for the patient is getting more attention. In 2008, there was rumor of an approaching storm, a new reimbursement model for non-complex hip and knee arthroplasties in Stockholm, which was about 78% of the hips and knees being done a year. It was a combination of two principles: the freedom to choose an accredited provider and a bundled, value-based reimbursement system. Managers and clinicians were invited to working groups designing the new model, and the logical background was then influenced by the profession, but at the end, the price was set by the healthcare authorities. The care choice for hip and knee arthroplasties was introduced in January 2009, and a bundle payment for ASA 1 and 2 hips and knees of 56,000 Swedish crowns or 8,500 Australian dollar was more than 20% below the previous reimbursement for just the surgery. But now everything was included: pre-op workup and visits, inpatient stay, implants, blood transfusions and labs, and follow-up visits and rehab. And to top it off, there was a complication guarantee without financial limit for all complications related to the surgery for up to 2 years. And no wonder most providers said that the risk was too great, they wouldn't be a part of it. But for Capio St. Göran's Hospital, Sweden's only privately owned but publicly funded emergency hospital, there was an opportunity. We were not satisfied with the quality, and we were not happy with the productivity, and the waiting time for surgery was far too long. So maybe this new system could catalyze the improvement process that we wanted. So I went back to my orthopedic surgeons and said that I was happy with a 20% price reduction. And that was the first time I had to head for a safe house because they were really angry. But eventually 12 accredited providers joined the model. And we realized quite early it was important to understand the intrinsic motivating factors for change to occur. Purpose, mastery, and autonomy were crucial factors. The influence of these external rewards seem to interplay with the intrinsic motivators, and in the public sector, the intrinsic reward of meeting patient needs seemed to be a particularly strong motivator. And the ability of leaders to translate these good intentions of a new model and align the external requirements with the professional values, the patient needs, and the quality was also very important. And to lose these good intentions through poor translation is a waste. Just have a look at Bill Murray's face. Professionals often have the same good intentions and can be valuable sources of knowledge when you design your governance system. So let's speak the same language. A thesis was actually published at the Karolinska Institute 10 years later in 2019, highlighting the need for increased collaboration and dialogue that brings professionals and policymakers together. This is a way to attain economic governance models that support and balance the multiple aims of healthcare and that are perceived as valid with reasonable requirements. We asked ourselves if we did things of value. Were we really as good as we could be? And the only answer to this question is no. And that has been the driver of our continuous improvement ever since. And we were really lucky because there was a national project being started by the patient insurance and the professional institutions at the same time, with the goal to decrease post-operative infections by 50%. And the program, it contained an analysis of the entire pathway. Were we really doing what we said we were? A self-evaluation and a peer review by national experts visiting our department and giving us feedback on what we did. There was a strong focus on prevention, just like in the reimbursement model, and there was sharing of knowledge and experience through a database with relevant articles on how to reduce infection. And the project, the bundle payment was not a project restricted in time. This was a change in culture, and we had to identify the factors for continuous improvement. Why became more important than how. And why? It was to improve patient outcomes and to reduce infection and complication. And we said that we would gain knowledge through actually doing things and evaluating them instead of just having yet another meeting. It was okay then to shoot first and aim later. Making a 7 with your first arrow was okay because in time you would eventually hit bullseye. Then failure was learning, but we wanted to fail fast so we could move on if it was not the right track. And that eradicated fear. So we would have more people coming on board with their sometimes crazy but helpful ideas. And we would start measuring the things that made people change their behavior, not measuring everything that we could, because there are a lot of things we can measure. And we would reward the people that shared ideas and made others better. So our top surgeons had in their personal goals to train more surgeons to do these surgeries in a perfect way. Then they would get financial rewards. Then the leaders had to set the standard. We had to walk the talk every day. And our hospital developed a new business model, a new basis for operation. And the most important thing was to analyze the patient needs, the diagnosis, but also the circumstances in life that mattered to each patient. The method and the quality was based on our 4 cornerstones with modern medical practice, good information, kind treatment, and the adequate equipment and environment. But it was the people that made the difference in the practice. So a clear organization, a reporting that mirrored this organization, and training of our staff so that they would perform excellent in their day-to-day work. But the true wheel of fortune was our continuous improvement cycle. And whether you call this a PDSA or something else, it's about analyzing, implementing, and measuring. And you measure your quality performance indicators like your clinical reported outcome measures, your patient reported outcome measures, or your patient reported experience measures. And of course, you have to keep track of your key performance indicators, your resources, so that you get the production and the productivity you need. And in the far right, you will get a sustainable financial outcome. And before we introduced this model, we spent every doctor's meeting talking about the financial situation in our department. And that is not something that orthopedic surgeons start to rave about. But after introducing the model, we haven't talked about the finances in 10 years. So what did we want to achieve? Well, we wanted the satisfaction of both patients and staff to increase, the efficiency to increase, the motivation to increase, and the reputation to get better. And we wanted to decrease the length of stay, the complications, the cost, and the stress in the organization. But to improve, you need to increase predictability. Variation is a problem both in terms of cost and of quality. And the more predictable, to be more predictable, you need to be standardized. But can you standardize orthopedic surgeons? For those who know an orthopedic surgeon, you know it's pretty much like herding cats or even worse. So what I did was I asked my surgeons that did knee arthroplasties if they followed the manual. Of course, they all said, we do it exactly the same way. I had a hunch that was not exactly the truth, so I put a camera in the operating room and I filmed for 24 hours around the clock for several weeks. And this is what the film looked like. It's probably one of the most boring films of all times because most of the time there's nothing going on in an elective operating room. So weekends and evenings, there's nothing going on, at least not in Sweden. But for the remaining about 15% of the film, I sent that to business school where students wanted to make extra money. So they watched every surgery and timed every little bit of the surgery to measure how long it took for each part of the surgery. And this is what they came back with. And this is not standardization. This is 5 different surgeons doing knee arthroplasties, and the same surgeon doesn't do another surgery that's exactly like the other one. And there's a huge difference in operating time between 35 minutes and 1.5 hours. And many of the different parts are done in different order. So some would cut the tibia before they cut the femur, and some would do it the other way around. So I showed this film and I showed this chart to my surgeons. And that was the second time I had to run for my safe house. But eventually, they started sharing experiences. So some of the guys that had longer operating times or did it in a different way would have sit-ins with their colleagues. So when I came back from my safe house, we agreed that we should be brutally transparent with all the information. So we put up screens in the corridors outside of the operating rooms, and we shared all the data that we had, the events, the adverse events, the failures, everything. And I started seeing the safe house in front of me again. But luckily, they've started to realize that it was actually beneficial if you wanted to improve. And we started showing our quality reports publicly so that all the different stakeholders could help us push the boundaries even further. And we were informing our patients so that they knew exactly what was going to happen to them, from the initial diagnosis of osteoarthritis to animated films showing all of the procedure and every step of the way in the hospital, hour by the hour. So they could help us and remind us that we had promised to do it in a certain way, and they were actually helping us to check and tick off the boxes. And we published the Book of Routines. It was almost as sacred as the Ten Commandments and the stone tablets. And it would finally include even the ASA 3 patients, the more complex ones, because the principles seem to be of benefit to them as well. And we had checklists to make sure that what we said we did, and that warning signs of complications were picked up early. And we introduced wound checks and easy access for patients who believed they had signs of infection so that we would be able to control the complications. So what happened? The average length of stay was almost 6 days before the start of the program in 2008. And we rarely did more than 3 arthroplasties per day an operating room. But after the bundle payment was introduced, the ASA 1 and 2 patients, the average length of stay decreased, and that's almost to be expected. But the interesting thing is that the ASA 3 patients also had a shorter average length of stay, so they seem to benefit from improved routines as well. And as the ideas spread to other orthopedic units in Sweden doing primarily healthier, non-complex hips and knees with traditional reimbursement models, it seemed like we were aligning the outcomes and the quality and the productivity more and more. And this year, now we're at 1.2 days as the average length of stay for all elective units doing the non-complex cases. And the comparable cost per patient was also decreasing. Higher volume meant better prices on implants, and we standardized implants. So today, all of our surgeons use only one knee implant. It's the best one in our national registers, but it's the same one at a very low price. Better technique meant less blood transfusions and less lab work. And shorter average length of stay meant less staff on the weekends. And modern pain regimens and infection control meant less cost for medication. So the cost went down. And we connected our documented routines to our documentation for individual patients. and daily published if there were any risks and the outcomes we had. And we standardized the electronic medical records so that we could get continuous feedback, not having to wait for the annual registry to report back to us so we knew what had happened to our patients. And for those of you who read Swedish, you can see that this patient in the post-op follow-up can walk more than 500 meters, and the satisfaction at the bottom is 4 or 5 out of 5 in the different categories. And to control and monitor the infections, we developed routines that were important for infection control. For example, the use of urinary catheters. And the written routines were connected to the individual care planning, and the outcome data was presented and finally fed into our national quality registers. And despite all of this work, the staff was happier and had fewer days of sick leave than comparable hospitals in Stockholm. And so that saved us money as well. And at one point, we believed we were on top of the world, having an average length of stay of about 3 days, traveling to other Capio units in Europe, showing them how to do it. Then we learned that the Danish had actually simplified the process even more. And as you do a knee arthroplasty, you get a spinal anesthesia in our hospital. And we also gave them a local infiltration anesthesia around the knee. So they were completely pain-free during the surgery and post-op. But still, out of habits and old traditions, we always gave them 10 milligrams of morphine in post-op. And if you give someone morphine that is not actually in pain, the patient gets very sleepy. So the working conditions in post-op was very good. The nurses were happy. There was not much going on because most of the patients were sleeping. And we were well staffed at the post-op unit. But as the patients were sent back up to the orthopedic ward in the evening, we had one nurse for 24 patients. And if you get morphine and you're not in pain, you often get nauseous. So the nurses would start running around with vomit bags. And after you've vomited, then you get dehydrated. So you need a drip. So some intravenous fluids. And if you've had your intravenous fluids, then it was usually time to check your hemoglobin. And you were diluted by the intravenous fluid. So the hemoglobin was low. That meant that you needed to get some blood transfusions. And when you get blood transfusions, we would expect someone to be bleeding somewhere, and you need to give them something to clot the blood. So tranexamic acid was given. And that has a side effect of nausea. So it was time for the second vomit bag. And after you've vomited again, then you're diluted, so you need more intravenous fluid. And the patient started to get worried that something was wrong because they were not feeling good at all. And there's a good drug if you feel anxious, and that's morphine. And so the circle started over again. We kept our nurses busy for at least 2 days just by giving morphine in post-op. So we said, why not stop this habit of giving them morphine? But that seemed to be very difficult because there's even a cupboard in post-op where it says morphine, and you cannot put anything else in there. We tried to say that maybe we should do what we do for kids and give the patients some sugar drink just to help them get started. Something pretending to have something to do with fruit like this festis. And that was completely impossible. So we went down to the local supermarket and bought a whole heap of these sugary drinks. And we told the patients to refuse morphine, and we hid a sugary drink underneath the sheets and asked the patients to take a sip. And they did. And those patients were not in pain. They were happy when they came up to the ward and wanted to go home the next day. And I was I was pretty new to the social media scene and everything, but I decided to take my first selfie. And I was so puzzled what we'd done for so many years. And from then on, simplification was a trademark. If there is no proven value added by action or medication, it doesn't make it into our routines. In 2018, there was an evaluation by the Stockholm County and the Karolinska Institute with the collaboration of Professor Michael Porter at Harvard Business School. And Professor Porter concluded that not only has the new reimbursement model encouraged providers to make numerous improvements in care, but complications have dropped substantially and waiting time has disappeared. And the report showed that initially the production increased, but as queues disappeared, then the production stabilized. And the waiting time initially, we had more than 30% of our patients waiting more than 90 days for surgery, and some waited for a year. So there was a buildup of patients that were not treated as the model started. And the initial cost in 2008 for a hip and knee was more than 13,500 Australian dollars or 90,000 Swedish crowns. And in 2009, it had decreased to 10,000 Australian or 66,000 Swedish. And on a payer level, reduced prices and risk transfer led to cost reductions of 20% for the county. In total, that was 60 million Swedish crowns a year. And the cost over the full cycle of care decreased by more than 11,000 Swedish or 14%. And so the total production increased by 21% from about 3,800 procedures to 4,500 procedures when Care Choice was introduced. But the total cost for hips and knees decreased. And there was no sign that we had a change in indication for surgery. And sick leave during the year before and after surgery declined by 17% or 38 days. This was probably a combination of reduced queues, improved quality, fewer complications, and political reforms. But that saved a lot of money for society and increased, of course, the quality of life for patients. And there was a shift of patients to providers with better quality and fewer complications. After a while, we could project the complication rate and cost and set aside money for these rare events. And the leftovers from this money could be financial incentives for the teams and the staff that reduced the complication rates. And after the reform, the report concluded waiting times for primary hip and knee replacement decreased, and the costs over the full cycle of care, as well as the risk of complications, were significantly reduced. And providers were also in general satisfied with the bundle payment model. And there were other notable improvements, like a 16% increase of utilization of the ORs, and the average number of surgeries increasing from 3 to 3.7 a day. And there was a 21% decrease of opioids prescribed, an 8% decrease of antibiotics prescribed, a 23% reduction in reoperations within 2 years, and a 27% reduction of adverse events. And the resources per treatment decreased, with 7% fewer doctor visits, 27% fewer inpatient days, and a 36% reduction of geriatric inpatient care. But there were still recommendations to improve the model, like securing financing for education, research, and innovation, and to expand the scope to include ASA 3 patients. Now, to develop these reimbursement models, it's important not to restrict the possibilities of innovation and development. The current model, it didn't foresee, it didn't support or draw any benefit from the now accepted practice to do hip and knee arthroplasties as day surgery. In the right setting, the cost can be dramatically reduced. And for the providers today, the care choice is one of the orthopedic procedures with the best financial margin. So developing the bundle payment for hips and knees further can benefit patients, the providers, and society. And if we look at the entire pathway in a holistic way, then we will get even more value for every dollar spent. But let's do it together. Thank you for your attention. And as the world opens up, please feel free to come and visit us in Stockholm.
Thank you very much, Tobias. And I'm looking at the comments from your presentation, which was very interesting, and you've certainly tickled the fancy of a number of the people watching. It's nice to have a bit of light relief as well on a Friday afternoon here in Australia. So thank you for your presentation and for sharing your sense of humour with us as well. So I will start with some of the questions that we've got coming in from our conference delegates. So the first question I'll ask is from Jane, and quite a number of people have flagged that they'd like it asked. Could you share a little bit more about the process of changing the surgeons' minds? I'm sure that there was more involved than you waiting it out while in a safe house.
That is true. I mean, it's of course a way of trying to put it in a comic way. There was a lot of discussions, but it was important to have these discussions and not just stay away from the important discussions on what was quality and what was actually value adding and what was just tradition and habits. And sometimes just holding the mirror up in front of yourselves by showing films or discussing some elements of our treatment that we all had taken for granted, that was important. It was, of course, a lot of discussions, but the climate to have these discussions had to be very open. And it was a culture change that took maybe 10 years. And we'd been working at the hospital to establish this culture for very long, even before this bundle payment model was introduced. So it's a cultural change. It's behavioral science in a way to show that you are interested in everyone's ideas. Everyone can contribute. There's no final answer. And you have to be a listening leader in order to cope with that. And orthopedic surgeons can be very blunt, so you have to take a few hits.
Well, I know that you also mentioned like leaders walk the talk. So presumably that's also leaders listening and possibly failing and learning from those failings as well in that environment.
That's true, and I mean this is just one of the patient categories that we treated. So if you were true to this, then there were other procedures that if you followed this logic, then you would lose a lot of money. For instance, we did hip fractures in a way that was adapted to the reimbursement system. So we used methods that were not perfect when it came to quality. And when we changed to the modern way of doing it, we lost a lot of money for that procedure. But it was important to sort of state the same values that we had in the bundle payment model, that you have to sacrifice something in order to be true to your values.
So you just touched on that you were looking at other areas as well. So were there multiple bundled payments being considered or being introduced at the same time?
This was the pilot model. It has since been introduced in different variations for a number of different specialties. Orthopedics has probably been the most successful one, with hips and knees being probably the best example, but spine surgery, where you develop criteria for individual patients so that the projected outcome can be measured against the individual prerequisites.
Yeah, I know something else that you're talking about the written routine, which is that like a care plan type documentation?
Yes, it is. It's
Yeah.
very detailed.
And so earlier you mentioned like the written routine alongside the individual care plan, and I suppose it almost sounds contradictory that everyone will have the same process and go through the same steps, yet it's still to be individualized.
Yeah, I think if you take this into the ASA 1 and 2 hips and knees has been one of the more standardized procedures it's pretty much the same for everyone, and that's why you can probably push the routines to be fairly rigid, but you can individualize information and things like that. But for the most part, is one of the easier procedures to standardize quite a bit. I can see problems when you go into other fields where you have to take even more to pay even more attention to the individual needs and adapt the programs to each individual patient.
Thank you. So early on in your presentation, you referred to the dollar amount that was set, and I have a question here from Elin. How was that reimbursement of the 8,000 Australian dollars, which was 20% less than the previous funding, I believe you were saying?
Yeah.
How was that arrived at, and the rationale that fed into this pricing?
I don't have the full insight, because after the clinicians and the managers had been part of designing the model, the door was closed, and there was calculation being done at the health authorities. So I'm not really sure how they came to this conclusion, but it was seen as unrealistic initially, and that was why there was only one or two providers that immediately said that we will go into this program, and that it was hard to calculate the risk of having these complications too without an upper limit. And we've seen examples where that can be a problem, but so the risk mitigation became very important, and we could see that most of the private providers would pay more attention to that than the public providers.
Thank you. I have a question here from Heon. How was patient satisfaction measured? Was it on a scale? And was this information successful in encouraging medical staff to be more efficient, ultimately driving quality and productivity?
Yeah, Sweden has a long-standing tradition with the National Quality Register for hips. It's been since the late 70s. And so all the patient satisfaction measurements were the ones used in the registers. There were a few new ones added. And the important thing was trying to have the feedback loop be quicker than the registers, because they would only give us the information a year later. So we needed to have the electronic medical records document the patient satisfaction. That could be published almost on a daily basis if we wanted. So, and we also had the patient experience measured by by different computerized polls that you could do at each ward and outpatient unit. But it was important with the feedback loop that if patients were happy, that would drive the behavior of the staff. We would do individual measurements, and that's not very common in Sweden. We measured most of the time, we just measured each department. But here we would measure each individual doctor sometimes on how he behaved in the outpatient unit, for example. But we're still not brave enough to look at each individual and the contribution in the process. So that could be a next development step.
With a little bit of time in your safe house.
Yeah.
There's lots of questions, and I'm not sure if you can see them from where you are, but lots of really positive comments here as well, Tobias, so thank you. Here's one from Andrew. What a fantastic idea, and has definitely resulted in better patient outcomes. But has it encouraged some surgeons or hospitals to accept the less complex patients or easier referrals with less potential comorbidities or less post-operative risk?
It doesn't seem that there's a difference in indication so that we would accept patients too early for surgery. That was something that we were fearful of, that would happen, because the prehab is not included. That is also something that we need to develop. So to have the physiotherapy and the osteoarthritis schools and so on being included in the total bundle, and having the possibilities of integrating new digital solutions for this could also be a possibility in the future. But we couldn't see that there was a difference in indication. We could see that the emergency hospitals would do the more complex patients, which is adequate. I mean, they have more resources to deal with that. And the most complex patients would be reimbursed through the DRG system with the ASA3s. And the private providers would stay more with the bundle payment. But both emergency hospitals and private elective units could be accredited in this bundle payment model.
Yeah, so there was just another question here from Robert, which starts TAC. There's my Swedish accent for you.
Is it Swedish?
I'm not sure.
Robert Swedish.
Very enjoyable presentation. I'd be interested to know whether you could consider this model would be as likely to succeed in the public and private hospital setting. So you just touched on that a little bit.
Yeah, I think it can be successful in both public and private institutions. It's a matter of culture, and the benefits from establishing this type of culture where you focus on what creates value, how can you get more healthcare for every dollar spent. That is so beneficial for the entire hospital that managers should consider at least creating this type of culture, not just in a specific bundle payment model, but influencing the rest of the care.
Yeah, thank you. Another question here. So it looks like the process occurred over several years, the change that was implemented. How long would you say it took from when you first raised the issue to new habits being incorporated as business as usual? And if I could extend that, if you were introducing another, cultural change, do you think you've had learnings which would allow it to be faster in the future?
I think so. It took at least 5 years this time, but it has changed our business model. So this is a mode that we use for different areas today, regardless of specialty, really. And so if I don't think we would get the same effect from a bundle payment model now if it was introduced for another specialty as we did then, because the difference was much greater then. Now the culture is there and the ways of working is more according to a value-based system already. But of course, there's some adaptations and things that a good system, and you need to put some work into designing the system to pick up the different details. But looking at complications and so on, in the old DRG-based system, it was really good business to do another surgery for a complication. That was a good margin. But now trying to reduce or make the revision surgeons obsolete or unnecessary, that's a different way of looking at it. And I think we should start working upstream. I mean, the final goal is to get rid of the need of orthopedic surgeons by having osteoarthritis schools and preventive measures and things like that. But if that is a difficult thought for an orthopedic surgeon, of course, that we might become obsolete. But that should be the ultimate goal.
Yeah. So given you, like you were just saying that, like the focus on value-based care has been established now, and so introducing a new system would have different challenges to it. So what do you think the biggest challenge would be if a new system was being implemented? What would that be?
Well, there are so many challenges with introducing the system, and I think that's maybe why it takes time to get it right. I think the most important thing is to be okay with the system not being perfect from the beginning, but you need to put in adequate time to get the key elements there. I mean, what kind of habits or behaviors do you want to encourage? And it's about leadership. So how do you lead people to change these behaviors and make it obvious that the old behaviors were not good enough? But the biggest challenge, I would say, is designing the model in a way that it stimulates the correct behaviors, because I can see that is really difficult.
Yeah. So I'm just scrolling through the questions here. So I think you've spoken about the impacts of the average length of stay is that in the acute component of the treatment? And Sharon Neal has asked, what impacts did these changes have on the rehabilitation component of recovery? Were there shorter and better outcomes with rehab?
Yes, it seems like if you measure the total time of both rehabilitation and the sort of perioperative period in hospital, it seems like the rehab period has gone down quite significantly. It's hard to know exactly what happened, because it was included in the bundle that if you needed to send a patient for inpatient rehab, then you would pay for it. So maybe there was reluctancy to actually do that. But at the 3-month and the 1-year follow-up, then we could see that the patients had the patient-reported outcomes were at least as good as they had been. So we're achieving the same end goal. But still, it's one of the big research fields in orthopedics, and after hip and knees now, is to speed up the rehabilitation period. And so we're looking into different models of having a digital companion that will coach each patient daily in that process, because usually it takes 3 months before the pain level is back to what it was before surgery, or the strength in the muscles is back to that level. So something is going on that we don't really understand, and we need to have more attention to speeding up the rehabilitation process.
Yeah, thank you.
So let's include that in the bundle too, I'd say. I mean, with sick leave, and you could expand this bundle to entail all of that process.
So that's the sick leave of the patient.
Yes.
Yeah, okay. Michelle Evans is asking a question about the project design, and that there's been a lot of training recently around lean thinking, understanding a problem before developing a solution for it, which is contradictory to your shoot first and aim later type approach, which she quite likes. How much does it need to be one model or the other, or does it need to be something in the middle?
I think it's really a combination of different things. We were really a lot into lean thinking even before we knew it was called lean, but it was about understanding the process and the elements and trying to get rid of the waste. And I think it's the shoot first theory is a lot about not getting stuck and postponing the learnings of failures. It's and you can combine that with the lean thinking. Sometimes you just don't know which road is the right one, but you have to start somewhere and then learn that it's not the right road and backtrack and get on the right track again. And so I think if you make it too theoretical and try to design everything from the drawing board in a lean system, then it will take so long that you will lose the attention of the clinicians. So this was a way of keeping the speed in the improvement process.
Thanks, Tobias. I have a question here from Gary. There's been a lot of talk about measuring patient outcomes from the patient perspective. Could or should this then directly impact payment models at the episode level of care? For example, if the patient outcome was at 5 out of 5, then their experience, and they would get plus 10% payment, or if they got the lowest score, have a percentage of the payment removed.
I think it's good as a signal that the patient reported outcome is important. It was about 3% of the total reimbursement that was withheld until we had the results of the patient reported outcomes and some quality measures. In the spine bundle payment, then it was about 10%, but still that was not enough, it was concluded, to change some behaviors. So it depends on what you want to achieve. I think it's a good signal that it's there, but you have to think really hard on the level in order to get a behavioral change. I think it might be even more than 10% of the total bundle, and then you might want to encourage other outcomes as well.
Okay. Brian Donovan's asked, were the savings ring-fenced for the orthopedic department?
They were, yes. I would say they were.
Let me see. Do you think the program would have been as effective if there wasn't concurrent infection reduction programs and the drive from upper executive at the beginning of the chain?
No, I think that was a key element, and that was, I would say, pure luck. But it was also part of the trend in those days to have more focus on the infection reduction. But it was easier to talk about the new payment model when we had this project. That it was the professional institutions were important to make the payment model legitimate in a way. So it was really helpful. I think you need to involve the professional institutions and get a drive from all different stakeholders to be successful.
And finally, in your continuous quality improvement, have you found value in using control charts to monitor process variation? If so, are you able to give an example?
We're not using it maybe in a structured way enough for it to be effective. We are talking we're talking more about the variation, and we're displaying the problems of variation in different ways. But it's not in a structured way really that we're using that feedback. We're still a little bit afraid to point out the individual factors of different staff members as being part of a problem. Instead, we try to make them come aboard the standard, but it's not like we're using charts of statistics to point to certain to the specific variations really. I'd like to do that, but we're not there yet.
That's all we have time for, Dr. Wirén. Thank you so much for your fantastic presentation today. Your flags in the background have also been noticed and appreciated. I hope you now go and have a great Friday. Enjoy your breakfast, and if you haven't already had a coffee, enjoy that as well. You've given us plenty to think about. So thank you, Tack.
Tack så mycket.
Thank you. And now it's time for us to head back to the timeline. We're ready for the final panel session of the conference. If you haven't already, please don't forget to vote for your favourite presentation. Voting closes very soon, so get in quick, and we'll be back shortly for the final panel session. Thank you.